Welcome back to session 8, entitled Imaging in Action, Concomitant LAA Workflows with TEE and ICE. For this session, we have a recorded case from Devi Nair, and we are joined by a fantastic panel of David DeLurgio from Atlanta and Rodney Horton from Austin, United States. And to the audience, remember, keep submitting your questions and claim your CME certificates for the program. Simply click the button on the webpage. And now, okay, with no further delay, it is me to hand over again to Devi to introduce us to your case.
Well, thank you, Julian. If I could just have my slides. All right, next slide, please. So what I'll try to do is kind of go over some of the workflows for, next slide, please, of what I use for my PFA with Farapulse and LA closure. And I think some of the important considerations that you'll see as we go through the workflow is, how we're planning for these procedures, what kind of pre-procedural planning are we using, how do we plan for venous access, how do we decide where we do our transeptals, and hopefully I can walk you through some of those workflows through a couple of these cases. And then just a little bit on the interprocedural imaging, where and how we, at least in my lab, how we decide between TE versus ICE as we have availability for both. And then, of course, the device sizing, etc. So if I can have my next case slide, please. So this is the first couple patients I'm going to show is a TE workflow. And I mean, these are patients that are coming to us that are indicated for LA closure. They're high CHADS vascular patients, high stroke risk patients that now also have an indication for rhythm control strategy. This is a patient that has persistent AF and needs rhythm control as well as stroke prevention. So if you could play the first video for me, please. So if a patient is able to have TE imaging, we actually go on to using TE. We have access to TE in our lab with imagers. So you can see I get pre-imaging before I do any ablation in these patients, so we have an idea of what it is. If I have the capability of doing CT, or if they've had CT done before, we will actually do pre-procedural planning. This is FIOPS that we're using to understand what the anatomy is like. And it kind of helps me decide where I want to do my transeptal. For my straight PFA workflows, I usually get 2 axes. It's always ultrasound axis. We do pre-procedural closure with usually per close in our lab. Of course, you can use whichever closure systems you want. Now, this anatomy, if you remember that CT, it was a posterior kind of windsock. So we decided for a more mid kind of transeptal. I tend to do ICE in my left atrium for my PFA. So you can see here I'm using a 2D ICE catheter for my PFA. So I'll take my ICE catheter into the left atrium. I'm not using fluoroscopy for the PFA part. So that's one of the reasons we use ICE in the left atrium, and using the pentaspline catheter for PFA. And you can see, I mean, we've seen through the day how this catheter is being used for PFA, but you can see we're looking at ICE to look for contact. We're looking at the OPAL software to look for the lesion tag assessment. Here you can see we're doing posterior wall isolation in this patient. This was a persistent AF patient that had really difficulty coming to the lab for their AF ablation. So we decided to actually do a little bit of debulking, just both PV and posterior wall isolation in this patient. And you can see this is a sped up video, mainly focusing on just what that workflow is for PFA and LA closure, not focusing really on how we do the PFA. So you can see this is a PVI posterior wall that's done. It's a pretty mass debulking of the left atrium, pretty big left atrium in this patient. And then again, for my LA closure, I believe in steerable sheets. I tend to, after I do my ablation, my imager will quickly get again a look at the LA sizing. We're using the true steer sheet in this case, which is a deflectable sheet for the LA closure. And to me, if I'm a little bit off in that transeptal, especially if I'm a little bit off anteroposteriorly, the true steer kind of helps. But in this case, you can clearly see that's a pretty coaxial alignment with that appendage. It doesn't have as big of a posterior take as we saw on the CT, but still the mid approach kind of helped us. And you can see we're coming with 3DT guidance there, coming into that flex ball. The anatomy with the sizing part on the CT was measuring for a 31 device. The post PFA measurements, we're looking at 27. I went for the 31 device. I like to go with the pre-procedure imaging more, and you can see here we're coming in with the device there, and you can see it's a nice implant. It's a single implant or single deployment. We're doing a tug test there. Again, making sure we have stability. You can see the auto markers. This is a Watchman Flex Pro device. You can also see that it's a very sick atrium. The LAA is quite thrombosed already. The contrast is kind of not going into the appendage as much. Even on the TE, you can see how the appendage is kind of more echogenic than it's not as echolucent. So one of those cases, we pay very close attention to the velocity within the appendage. So some of the things to keep in mind as you're doing these concomitant workflows, again, making sure our imaging and stuff is okay. Now, one of the things you'll see, if we know that this is good, again, you can see I deployed the device. I like to do a post-implant angio. I know it's committed, but I like to make sure that it's still in a good position and there's no tilt. And again, you can see that LA is fully thrombosed off already in this patient, even though we only did a PVI and posterior wall. And a quick assessment with ICE. Now, in this patient, I had TE access. Even though I had ICE in the left atrium, I used TE for my implant. Now, this is a different case where we did the CT, and you can see it's a very anteriorly directed appendage. And of course, the transeptal changes in this patient for me. For an appendage like this, where I know I have to come really low and anterior, this is one of the reasons I like to do pre-imaging in these patients. And you'll see that we'll do our transeptal really low, really anterior in this case. And I think one of the things that I've kind of paid a lot of attention to is, in this case, you can see on ICE, I'm actually looking at the appendage and coming straight at the appendage in that low anterior take. I like to bias my transeptal for more of a LAA management than PFA. And you'll see once we come into the left atrium, sometimes it is difficult to take the ICE into the left atrium in that low transeptal approach. And sometimes you actually have to get a double transeptal for ICE in these cases. But you can see we'll go through a PFA workflow really quickly. And if you can maybe advance that video a little bit for the sake of time, you'll see once we finish the PVI workflow, we'll move on to the appendage. I don't really change my workflow, from PVI to LA closure. I stick to the true steer. I like the deflectable sheet for my workflow. You'll see we'll finish up PVI. In this case, I'm doing the PVI first, looking at the really went for that posterior wall, mainly because there was not much of a critical isthmus or much of a distance between the veins. You can see it's not much extensive of a PVI there or posterior wall there. Coming back and measuring the appendage. Again, I will go with my pre-procedural imaging. I'm doing post-PFA imaging mostly for academic purposes, just to understand, if there is a difference. And where historically we've seen about 2 to 4 millimeter difference in sizing, depending on where we did our ablation. And you can see our transeptal is pretty reasonable for that very low takeoff. Very important in this anatomy. You can see there were a lot of proximal pectinates that we come in a very a coaxial manner. And you can again see not a very super compressed device, a little bit under compressed. but not, it's still reasonable in my mind. Again, 31 millimeter device in this case. Could have done a 35 probably, but 31 looked appropriate and still looks reasonable, with a reasonable coverage of the appendage. Has a little bit of proximal shoulder in some of that T imaging. So mostly from that edema that we saw. And so I didn't feel very comfortable going to the 35 size. So I stuck with the 31 size in this case, and still with a good implant. If I can go to my next video really quickly, I want to quickly show a case where we had a patient that had esophageal strictures and also had CKD, so we could not do CT imaging or TE imaging. And in these cases, these type of cases where I don't have pre-imaging, I like to use 4D eyes. So you'll see in this case, we went on to doing a 4D eyes or 3D eyes directed PFA LA closure workflow. And again, with that, I'll say that I'll actually look at the appendage with my eyes and kind of plan my transeptal based off of that, since I don't have the advantage of having pre-planning. And you can see the ICE catheter is in the left atrium. I tend to take my ICE catheter into the left atrium through the same transeptal. Here you can see the appendage. We'll do some pre-imaging or pre-PFA measurements really quickly. And Julian, I can kind of bring it back to you. This is actually the new software with the Opal system. You can see we're using the contact assessment tool for the PFA application. And I'll let the video play, and if you want to kind of bring in some questions and bring the panel in while the video plays in the background. And what you'll see is a PFA workflow with Opal and Fairwave, and then LA closure under 4D eyes guidance. And we'll let the video play in the background.
Wonderful. Thank you, Devi, for presenting again a beautiful case and beautiful examples. And maybe I start off with asking David, from your experience, and Devi pointed out that she designs the site of the transeptal puncture based on the takeoff and the relation of the left atrial appendage. So if you, in your practice for concomitant cases, so we're speaking about concomitant cases, do you take more, or is it for you more important to ensure proper access to the appendage or proper access with best contact to the veins? What are your thoughts on this?
Thanks for the question. So like Devi's workflow, I tend to use a single transeptal puncture. And one of the potential disadvantages is that you might not be optimized for both procedures when you choose one site, as you're alluding to. So I'm very big believer in pre-procedural imaging like Devi does. I use CT scanning because I really get to think critically about what's the best transeptal puncture for either. And if I have to compromise, which one should I bias more towards? So if it's a very small atrium, I hate to be anywhere but anterior because it can be difficult for the ablation portion. Now, fortunately, for most cases, you can optimize for both in transeptal puncture at the same location. When I have to choose, I choose a little more bias towards the left atrial appendage because I feel like I can always figure out how to get the ablation done if I have to, and even bring in other technologies if I needed to. But if I can't get a good Watchman position, I think I really compromise the intent of the entire procedure. So when forced to, I bias more towards a position that optimizes the appendage closure.
Yeah, thank you. And maybe we hand over the next question to Rodney. And Rodney, my question for you also would be to, with all the, let's see, improved technology, also the improved mapping technology, and we see a beautiful example running in the past, in the back. If you had to decide on the additional imaging, TOE or ICE or ICE. So what are your thoughts? What could you, if you had to, what would you leave out of the equation?
Well, so a very good, and it's kind of a timely question these days because with PFA, everything is moving much more toward independent operators and not being, there's a little bit of a bandwidth problem if you include like either a cardiologist in the room so that they can do the esophageal echo, or a cardiac anesthesiologist, things like that. So we've sort of shifted away from being completely dependent on TEE or TOE for some time, and this really predated PFA ablation. I so generally I will make two separate punctures for the transeptal. Now I'm not completely obsessive about that. I think if a transeptal puncture was an extra 20-minute procedure, I wouldn't be doing it. But the reality is the second transeptal puncture is about an extra 40-second added part to the procedure. So my normal workflow is to puncture kind of mid, purely to make a hole. So that's where my ice is going to go through.
Right.
And then I will pull back. I know it sounds kind of silly or counterintuitive. And then I will intentionally puncture lower and usually a little bit more anterior. And that's the puncture that I typically will use for the PFA. And it usually ends up being the perfect entry point for the appendage closure. Now, there's occasion, maybe twice in the last year, I've had a patient where if you stick low and anterior and you happen to have an appendage that has a very posterior bend, in other words, is pointing kind of toward the apex of the ventricle, then a low anterior puncture is not helpful. It's actually harmful. And in those couple of cases where that's actually happened to me, I simply reverse, I use the same holes. I simply switch which sheath goes through which. And it adds about a minute to the procedure. And so then I kind of do it that way. Now, I'm not saying it's the only way to do it. I think that if you have a real tricky septum and you really don't want to puncture twice, I wouldn't feel bad about it. I think that's fine. But I do realize that there is some catheter interaction. In fact, earlier today, I had a case where I had a real thick, difficult septum, small left atrium. I thought, I just want to puncture once. And I found that my ice catheter was sort of draped on top of my Watchman sheath. And so I had to use old X-ray to flip them around because it was actually interacting. And it's not something that I usually have to notice when I'm making two separate punctures. And 99 times out of 100, the low anterior puncture is really the optimal puncture for both the PFA and the Watchman. But about twice a year, it's the other way around, in which case we simply switch them out. I know it sounds kind of weird, but it's not hard to do. And once you have those two access points, it's pretty easy to reverse them.
Yeah. And Rodney, are you also using on a routine base the CT before in order to have a pre-procedural idea where to design and how to design your transeptal, or do you decide during the flight?
If someone has had a CT, I will always take the time. I kind of tell the patient, look, you went to the trouble of getting it, you went to the trouble of paying for it, I might as well look at it. But I don't typically do it as a matter of course, and I certainly don't hold up the case because of that. And part of that is because patients are coming from so far away. It's a little bit hard to cobble together that data. And I don't really think it's a good idea to do like a CTA the day before, because it's a pretty good dye load. And then if you give them any additional contrast during the procedure within 24 hours of the previous angiogram, you're kind of pushing nephrotoxicity.
Yeah. Thank you. This may bring me over to David again. One more question, and your perspective on the topic. Sometimes, if we have CT scan, ICE, and TOE data for measuring the landing zone of the LAA, there's conflicting information. And I like Devi said she would most likely go, and you said it a couple of times, with the CT data. What is your approach in this? How would you decide?
Well, quite frankly, I consider the CT data to be more absolute. But like many people, we noticed that the echo data suggests a slightly smaller appendage at the time of the procedure, whether it's in our case, when we do standalone Watchman, we use TEE. And for my concomitants, it's 100% ice only. And regardless of the echo technology used, we tend to get a somewhat smaller um, appendage measurement when we're using the echo compared to the CT done prior to the procedure under different loading conditions, and of course with a more three-dimensional type of measurement. So I never forget what I saw on CTA, but if I truly see something on TE that looks like it's impossible to stick to my original measurement, I could downsize. But I learned long ago from Rodney really to insist on upsized devices to get our best compression and seating. And I've adopted that. So I tend to go towards the larger size of the spectrum for the cases. And I find that the CT really the injection almost always looks like the CT. So the fact that the echo takes you to a slightly different measurement to me says that it's just the way echo is measuring. It's not always getting the best angle on the appendage.
Right, right. And also, again,
Julian,
maybe
can I ask a
switching.
question?
Yeah,
Yeah.
sure. Absolutely. Yeah.
No,
Please.
can I ask a question to Rodney and David? You talked about oversizing, I kind of don't call it oversizing. I call it sizing to what we saw on the CT. But sometimes, rare occasions, say, especially if you're ablating quite a bit around the pulmonary vein or you're doing olive lesions, you will see a lot more edema. And there are times where I've seen quite a bit of discrepancy between the CT and, say, the TE or ICE. And I feel like maybe it's not the same. It's not the day to put the device in. Do you ever feel like it's okay to maybe not do a concomitant case sometimes? Is there certain scenarios where you would say, yes, I planned it as concomitant, but today is not the day for it?
Well, let me talk since David talked earlier. One comment I would say about the CT versus TE with regard to imaging is I completely agree that CT is going to give you a lot more spatial information. It's going to give you a lot more anatomical shape information, and the anatomical shape does not change. But if you're talking about the actual measurements, so the size of the appendage, you think you're talking about the same thing and you kind of aren't. And the thing we have to realize, and I will get to Devi's question, is that the appendage is a little bit like a water balloon. And so if it's a partially inflated water balloon, it's going to look a certain size. But then if you put more water in it, it'll open up and its shape won't change necessarily, but the size will change quite a bit. So CT gives you fantastic anatomical geometric information, but it's also static. It's as David mentioned, volume status could be different, so that's different. And so I think taking the shape to the bank is safe because it's accurate. Getting hung up on the number and the size, you might get fooled. And so one of the things that we've learned is if you put something in the appendage, like for example, a pigtail wire, something that's going to kind of open it up, you oftentimes will find a much different size compared to what either the TEE indicated or what the CT indicated. And so you can't like go down that rabbit hole of my CT told me a 27 millimeter device, so I'm not going to think any further. I'm just going to go with a 27 millimeter device. I think that's a mistake. I think once there's something in there, even if something temporarily in there, you may come up with a very different bit of information. Now, finally getting to Devi's question, I absolutely think that even if something is scheduled as a concomitant procedure, we reserve the right to say, look, this is the right day for it. And either because there's potentially some safety issue or some anatomical change that we know is going to be dynamic. If you have this really inflamed left atrium or edema right at the ostium that you know for sure is going to be gone in 3 or 6 weeks, maybe it is the best thing to do is to wait, because what you don't want to do is put something in that in retrospect was sort of undersized. It didn't look undersized because of all that edema. And then once the edema goes away, it's grossly undersized. And then you potentially have a problem. So the CT, I believe in CTs and I believe in TEs. I am less impressed with the consistency of the measurements with either one, because once you stick something in there, it oftentimes looks very different than what it does when it's empty.
Wonderful. Thank you very much. Unfortunately, we are running out of time. So therefore, I want to thank, of course, Devi for presenting a beautiful case or beautiful cases and also sharing your thoughts and experience. David, for also commenting and also sharing your experience and thoughts on this interesting topic. And of course, Rodney as well. Thank you, guys, very, very much. And therefore, we will move on to the next session. And we have coming up a symposium entitled The Integration of Varipulse and Cartridge Sound for PVI, starting in roughly 1 minute. So stay tuned. Have a good night.